promise to affirm that testimony about the giving the truth, the whole truth, nothing but the truth?
I do.
Pleasure.
Good afternoon, Doctor.
Good afternoon.
Please state your name for the record.
My name is Mark Harper.
Dr. Harper, we've retained you to conduct a compulsory medical examination of Dannette Griffith in this case. And to start off, to help the jury out understand who you are, could you give a rundown of your education?
Sure. Starting with undergraduate, I attended North Carolina State University in Electrical Engineering, and subsequently University of North Carolina Chapel Hill for chemistry, biology, and psychology, and a short period of time in the Division of Rheumatology at the University of North Carolina Chapel Hill for attending the University of Vanderbilt Medical School. Subsequently after that, I did my orthopedic residency at the University of South Carolina, including Palmetto Richland Hospital, Dorn VA Hospital, and Greenville Shriners Hospital for Children, and then subsequently University of Virginia for spine surgery fellowship. And after that, in private practice, I was on that staff position at the Cleveland Clinic, and then returned back to private practice.
And are you board certified?
I am
In what?
orthopedic surgery, spine subsection.
So your specialty is as an orthopedic surgeon?
Correct.
And is that your primary practice?
My primary practice is orthopedic spine surgery.
Now, you've been asked to look at the records of Dannette Griffith and do a physical examination of Dannette Griffith, and you provided us a report. And before we go over that, I'd like to just watch your eyes, sir. You did review the medical records that we sent to you, correct?
I did.
Okay. So you reviewed records, Cameron Memorial, Orthopedics Northeast, Health South, Ready Med. I won't read them all, but the treaters of and doctors of Miss Griffith, when she was in Indiana, and came into Florida, physician's choice, Sarasota spine specialist. Dr. Regal, Doctors Hospital, Rose Radiology, Workers' Comp, Healthcare American Physicians Group, Daniel Merck, Dr. T.C., Kennedy White Orthopedic Center, Suncoast MRI Center. We go on. And we looked at her prescriptions she's been taking, accident report. You looked at her deposition. You looked at the records of Dr. Hauser, Pain Medicine Institute. Is that pretty much covered?
It was in this box I looked at.
Okay. You had the opportunity to examine Ms. Griffith on what date?
Return back to my original note. It's dated May 4th, 2012.
All right. And what did you initially determine from looking at her records?
That she had sustained an injury to her cervical spine in a motor vehicle versus pedestrian accident in Indiana previously, ultimately had some conservative management which had gone on to not be satisfactory for her and had been recommended for a procedure known as anterior cervical discectomy infusion, which she underwent, and subsequently had chronic pain management for this for non-remission of symptoms and having continuing headaches, continuing neck pain, continuing arm pain, and subsequently was involved in 2 other motor vehicle accidents, continued to have significant neck, head pain, shoulder pain, arm pain, and undergone treatment with multiple pain management physicians, treatment with chiropractic physicians, treatment with other orthopedic specialists without avail.
And that was before the accident we're here for?
Correct.
I didn't mean to interrupt you.
She also had an injury to her ankle when she was in Indiana, which did apparently respond to conservative treatment. And at the time that I saw her, she was complaining of significant headaches, which were fairly consistent with her pre-accident condition, consistent neck pain and arm pain, which according to the medical records were fairly consistent with her pre-accident condition.
Did she tell you anything about the motor vehicle accident that she was involved in June 6, 2007?
She described that she was sitting at a stoplight and a pickup truck was in front of her and backed into her. She described that the speed was relatively high. She did recall the accident did have no amnesia. The accident did not require emergency services for the accident.
And she told you about being able to work at Terminex. She was working at Terminex?
Correct. She said she was working at Terminex, and she said she was climbing around in attics and performing inspections.
And following the accident, she continued with what sort of care?
She was receiving pain management through various pain management physicians, using opioid pain medicines, and getting chiropractic manipulation.
All right. And you noticed through your records, read through in her records that she was treating with a chiropractor?
Correct.
And what sort of treatment was he giving her?
Manipulations. One was a manipulation under anesthesia, where the patient essentially is being put under anesthesia, aka asleep, and having their extremities or their head manipulated, essentially cracking their neck or moving their shoulder around.
Now, the treatment with the chiropractor is Dr. Dietz, is that correct?
I believe that's correct.
And the manipulation under anesthesia, the cervical spine, that was before the accident we're here for?
Correct.
Okay. And do you think that was a good idea?
I do not think that was a good idea.
All right. Tell me, what are your opinions about manipulation under anesthesia?
Relevant, Your Honor.
I'll overlook that. Go ahead, you answer.
As far as manipulation of cervical spine under anesthesia, it's certainly a bad idea for a number of different reasons. Number one is that you're not able to protect your cervical spine if you're asleep. And if there is a particular feedback mechanism that's telling your brain that you shouldn't be doing something, you're not allowing that to kick in, and so you can manipulate something past the point of injury. The most common injury pattern associated with chiropractic manipulation of the cervical spine is something known as vertebral artery dissection.
Objection, Your Honor. Relevance, may we approach?
All right.
In your practice as a physician, as an orthopedic surgeon, do you have come in your office folks that have been involved in motor vehicle accidents?
Absolutely.
All right. And do you have an understanding of auto accidents and how they can affect the body?
Absolutely.
All right. And is that based on your experiences in orthopedic surgery?
Correct.
All right. And you also you have a post-baccalaureate degree in biomedical engineering from the University of North Carolina.
Did not complete those studies in that in biomedical engineering.
All right, but you did study.
Yes.
All right. Now, assuming that this accident was a motor vehicle collision that was 5 miles per hour or less, do you have an opinion, a general opinion about whether such a collision would cause injury?
Excuse me, Your Honor, may we approach?
Sure. Let's go to the exam that you did of Ms. Griffith. Tell me what you did with Ms. Griffith to examine her physically.
Well, I did a general examination, essentially looking to see if the patient has any overwhelming other systemic conditions, which didn't seem to have at the time. And then, of course, looking at a neurologic examination of the extremities is really important also to looking at the spinal cord itself. And essentially showed some generalized weakness in her hands, which was minimal, with relatively normal reflex exam and of the upper extremities, and a little bit of decreased sensation, and a relatively non-specific pattern in the upper extremities. Lower extremities were relatively normal in the exam, neurologically speaking.
Now, you state that she has a negative Hoffman's bilaterally. What does that mean?
A Hoffman's exam or Hoffman's reflex is actually a return of an infantile reflex. People may be familiar with putting a finger in a baby's hand and dragging their finger. And that's actually a spinal reflex. It's a reflex that doesn't exist in the brain as it comes through their spinal cord and into their hand. And as we grow older, we learn to suppress that reflex, and that's an active suppression from the cerebral cortex down to the spinal cord level. And so if there's a discontinuity in that information because of a spinal cord injury, then that reflex returns. So it indicates some sort of spinal cord injury or previous spinal cord injury.
And that was not indicated there, right?
She had a negative exam indicating that she had no disinhibition.
All right. Now, you stated that her upper extremities were basically normal.
Except for a slight weakness in the hands distally, so that the grip overall is relatively normal.
Okay. And she had 5/5 biceps, triceps, and brachioradialis.
Brachioradialis, that's the muscle that does this.
Okay. And those were normal?
Correct.
Okay. And she had negative carpal tunnel compression test bilaterally?
Correct.
And the lower extremities have good range of motion in all major joints?
Correct.
Matt, did you make her flex and bend?
Passively and actively.
All right. And was she normal?
She was within normal limits.
You stated she has 5/5 EHL. What is that?
Extensor hallucis longus, so that's the muscle that pulls up your big toe.
All right. And that was normal?
That was normal. That's a unique indicator for the L5 nerve.
All right. And the L5 nerve root is the low back area?
Correct.
And FHL?
Flexor hallucis longus, that's the nerve, the muscle that pulls the big toe down, and that's usually S1.
All right. And that was normal?
Correct.
And gastrocs?
That's the big muscle in the back right here, and again, that's S1. And that was normal.
And hamstrings and quadriceps?
The quadriceps is a big muscle on the top, the hamstrings are a muscle on the side of the back of the leg. Hamstrings are usually L3, and quadriceps are usually L4.
Now, you do know that Ms. Griffith Griffiths had prior cervical surgery.
Correct, that's what she reported.
And you did some diagnostic testing as well?
We did some x-rays at the time of her exam indicating that she had a fusion done in C5-6 and C6-7. The instrumentation looked like it was well in place with no evidence of breakage of the instrumentation or loosening of the instrumentation. That would be the plate and screws holding things together in the front. And the C5-6 looked as if it had solidly fused. The C6-7 was a little bit more difficult to assess. I recommended the CT scan, which is really the study of choice to determine whether you have a solid fusion or not.
Now, do you have an opinion about whether the spine is more delicate at the point of where the cervical fusion with the instrumentation has been provided to a patient?
The data don't support that. The data support after solid fusion that there's no hysterical or major hysterical loading, especially to the point of riskiness or failure.
Would you consider Ms. Griffith an HL patient or plaintiff?
I don't understand exactly what you mean by eggshell, but what you mean prone to fragility fractures, no.
What was your overall assessment and plan for her?
Well, she had a very confusing constellation of signs and symptoms indicating a complex pathological situation. She had been diagnosed with a condition called cervical dystonia. This was not my diagnosis. This was one she carried. I didn't feel that I was capable of really ruling in or ruling out whether or not she had that condition. It seemed to me that she overall had deteriorated slowly over time, essentially from her previous injury from the motor vehicle accident where she was actually hit with pedestrian versus motor vehicle accident, ultimately resulted in having a fusion of the cervical spine. And overall, I recommended just a CT evaluation of her cervical spine to make sure that the cervical fusion had indeed happened, as I would any person that walked in my office, because it's something they should know potentially can be affected later or treated later. But beyond that, I didn't really feel that the data supporting or the information I had supported a significant injury or significant chronic condition resulting from the accident she had in 2007.
What injuries, if any, did Dannette Griffith sustain from the accident June 6, 2007?
At the time that I examined her, I really don't think that she had any persistent injuries from that particular accident. At the time, she probably had a mild cervical strain or muscle strain that in most cases would be self-limited. It works to go away on its own without any treatment.
Do you have an opinion on whether she sustained a permanent injury as a result of the June 6, 2007 accident?
In my opinion, I don't think she did.
And you found that she had no discernible spinal neurologic deficit, correct?
That's correct.
Now, you do mention in a report about prognosis, despite what you find this auto accident to have caused. What is your prognosis?
Not good, and the reason being is she has such a chronicity. She had been requiring opioids, had multiple treatment regimens, multiple treatment modalities, which have failed providing a significant improvement over time. She's appeared to continue deteriorating. So as far as her prognosis is concerned, I don't see a good prognosis for her overall. And in lieu of the fact that so many physicians had been treating her and had been able to come up with a unifying idea or etiology for her condition. Unless you can identify the condition, it's very hard to treat the condition.
And you believe that she'll require remedial care and treatment in the future?
In my opinion, yes. I didn't think that she would require some remedial treatment. essentially because of her complaints. As far as her physical exam goes, I didn't find anything really compelling for her to do one thing or another. But as far as ongoing pain management, it appeared that she had a chronology with that and probably required it over time.
You don't find that the treatment is necessary as a result of the July 6, 2007 accident, do you?
No, I do not.
Right, Doctor, have all of your opinions been made within a reasonable degree of medical probability
Yeah.
and certainty?
Yes.
All right, thank you.
Hey, Cross.
Thank you, Your Honor. Hi, Dr. Harper. My name is Matt Powell, and I represent Dannette Griffith. How are you today? I'm fine. How are you? I'm good. Let me ask you a couple questions. About what date were you hired by the defense team in these cases?
Honestly, I don't know how to answer that question. I know I performed the IME,
Oh, excuse me. Compulsory medical examination?
independent medical
Excuse me, Your
examination.
Honor. Can we approach?
Okay. Okay, ladies and gentlemen, you heard the term independent medical examination. Disregard that as a compulsory medical examination. So
Thank you, Your Honor.
let's pick it up.
I appreciate it. When did you first do your compulsory exam at the request of the defense team?
May 4th, 2012 was the day.
And how many years was that after this movie?
Ostensibly almost 5 years.
Okay. When did you graduate medical school?
1999.
When was the first time you did any type of compulsory examination on behalf of defense teams? Or workers' comp, anything like that?
Honestly, to my recollection, this would be the first.
The very first one?
As far as I know, I don't keep a record in my mind of that.
Okay. So if it's your first one, I take it that when you were retained, you already had, may I approach the witness?
You may.
I guess is this a fee schedule from your company?
This is sort of my current practice, but this is not from the practice I was with at the time of this.
Okay, you changed practices?
Correct.
Do you have a fee schedule from the time that you were asked to perform this examination?
Do I have with me? I don't think so.
All right. Do you have with your file the records and the letters that were sent you by the defense counsel about this?
Honestly, we'd have to look through this box. And we see it's a large box.
And Your Honor?
Thanks.
These contain all the records that you were provided, right?
Correct.
And so if there's records that exist and you weren't given them, you're somewhat of a disadvantage. You agree with that?
If I'm not given the records, I can't count on them.
Okay. So, Doctor, do you have a file that contains correspondence with Mr. Fisher in his office?
Sure, I probably do in my office, yes.
You didn't bring that with you today? You ever testified in court or in a deposition about an examination of the patient?
Not in court, I've done a deposition.
Okay. It appears that just parts of your file are here. Give it back.
Okay.
Do you know who put this note on it? Happy reading?
Yes, my assistant did.
Okay. Did you read everything in there?
I did.
Okay. Did you find that, in fact, Mrs. Griffith did have surgery on her Achilles tendon?
I have to go back and look again. It's a large thing.
So in your report, you indicated that she didn't have surgery. In your testimony earlier, you said she didn't have surgery.
It's a conservative treatment, which usually means non-surgical management.
Which usually means what?
Non-surgical management.
Okay. I'll read right out of your report. Achilles tendon trauma, which was treated without surgery, right?
Okay.
All right. So if she had surgery, it's in the medical record. She didn't quite pick that up.
Correct.
Now, you've never been involved in any sort of treatment of Dannette Griffith, correct?
Absolutely not.
You can't make a diagnosis for her because you're not a treating physician.
That's not true.
You can't order tests for her.
That's not true.
You don't have any patient-doctor relationship because she hasn't consented to any such relationship with the patient.
I don't know that she has or has not.
Well, let me ask you this. The patients that you treat that come in and pay you, they have a doctor-patient relationship with you, right?
Any patient that asks my opinion and for treatment has a doctor-patient relationship.
Did Ms. Griffith call you up and ask for you to examine her, or were you sent to her by the defense team?
I don't know the answer to that question.
Well, let me ask you this. Did you charge any money for your examination of her?
Yes.
How much?
I don't recall.
Okay. Well, I guess with your current employer, it looks like you guys charge $2,000. Okay.
Yes.
Okay. And it looks like you also charge a $250 chart preparation fee.
Correct.
Right? And you charge a $2,500 fee for videography, correct?
Yes.
Okay. And that was all paid by the defense team, not by Dannette Griffith.
If anything applied, yes, it would be probably paid by them. I understand.
Okay. All right. Now, you indicated that in your practice, you do treat people for motor vehicle crashes, right?
Correct.
And would you agree that some people, and we'll just try and make it more narrow, females between the ages of 40 and 50, or Dannette Griffith would be right in the middle. Some people, they're in a motor vehicle accident and they make their fine recovery and they have no residual losses.
Yes.
And would you agree that, some of your patients get into a motor vehicle crash, and despite all the best effort, treatment, care, testing, they just don't quite make a great recovery?
Very rarely.
Okay. Rarely. So not all people respond. Some people don't.
Absolutely.
Okay. And we call that, some people that don't make it, like the miserable minority, those few people that no matter what you do, you just can't get them fixed. Is that right?
Sure.
Okay. The doctor is an orthopedic spine surgeon. You're not suggesting that Dannette Griffith needs any spine surgery, right?
Again, I recommend a CT scan to determine whether or not she has osteoarthritis in C6-7. If it was symptomatic osteoarthritis, then that's something that can be treated surgically. However, until that's done, we cannot make a recommendation one way or the other.
Okay. If she has, let me find the exact word they use. If you did the CT and she needed the surgery, what would it fix?
It's difficult to say.
Okay. So as we sit here today, you have no reason to suggest that she get an orthopedic surgery.
As I stand here today, I have no opinion on whether or not she needs or does not need any surgery of the spine.
Okay. And you are not board certified in pain management, correct?
No.
Do you refer patients to board certified pain management doctors? Okay. I take it from your testimony you don't refer people to chiropractors.
No, I would disagree with that.
Okay. All right. Some people do, some people don't. All right. Now, agree that some people have pre-existing conditions, and then they get into a motor vehicle crash, and that they're more susceptible to injury because of the pre-existing conditions?
That's way too general a question.
All right. How about if someone has a 3-level fusion in their cervical spine, and then they're involved in a motor vehicle crash? They go through a whiplash type of event, that they're more susceptible to injury than someone who doesn't have that condition.
I don't have any data to support that. And again, the term whiplash is, I can't use that term because it's never used appropriately.
Okay. How about cervical acceleration, deceleration? Is that a better term?
Yeah, that's a better term.
Okay. You say a person who has a 3-level bone fusion is at greater risk of a cervical acceleration, deceleration injury.
No.
Okay. Would you agree? Well, let me ask this. In your profession, I imagine you fuse bones in the cervical spine, right?
Yeah.
You do the same kind of surgery that Dannette Griffith has.
Absolutely.
Would you agree that that reduces the patient's range of motion?
Of course.
Okay. So when you said earlier that she had a normal range of motion, did she have some epiphany that her neck, despite the fusion, was more flexible than people that you've operated on?
Can I expand?
Yes or no would be a fine answer.
Do you want me to say yes or no or expand?
You can answer yes or no, and then you can explain your response.
I would say that, actually I forgot the question. Okay, can you ask me again?
Yeah. I think you testified earlier that when you did a range of motion test on her cervical spine, you found it to be normal. And I just asked you a question before that. If you fused 3 bones in the neck, does it reduce the range of motion? You said yes. So they seem to be irreconcilable answers.
Actually, I don't have anywhere in my head that I did a cervical spine range of motion exam and found it normal.
I was just listening to your testimony from the questions for
That's from the extremities.
No, I'm really careful. I mean, this is what I do. Listen
I
about
have
the
my
neck.
note right here.
Yeah, but nowhere there's this. All right, well, let me ask you this. Did you do a neurological exam?
I did.
Okay. I would like you, if you could, please, to name, how many neurological cranial nerves are there?
There are 12 cranial nerves.
Can you name them?
The olfactory, the ocular, there's the abducens, there's
The what? Go slow. I'm checking them off. I want to make sure you got them. You said the olfactory, the ocular motor.
ocular motor, there's the spinal accessory, the hypoglossal, there's
Trigeminal.
trigeminal.
Objection, Your Honor. It's not allowing him to finish
Let him
that.
finish his response.
Did you get the hypoglossal? There's no particular order.
I understand.
And there's the facial, trigeminal, the vestibular, the otic. I'm not sure what number we're up to now. I usually don't count them. There's 1 associated with the nose, 3 associated with the eye, the facial, the trigeminal, the hypoglossal, the vagus nerve, number 12, and spinal accessory nerve.
The what?
Spinal accessory nerve. I can give you the exam and test all of them.
I just want to know if you know the names of them. I mean, you gave the test, you wrote it down. All right, let me tell you what you got right. Olfactory, ocular motor, trigeminal, facial, vestibular, right? Glossopharyngeal, the Vargas, or the Vegas, and the
Hypoglossal, spinal accessories, number 11.
Got it? You did pretty good. You only missed 2. All right. How much are you charging for your time to come here today?
I don't charge by the hour.
Okay. How much are you charging for the day?
Typically for court appearances, I mean, it's $9,500.
$9,500 for you coming here today?
Correct. Again, I've never appeared in court before. This is my first time.
Okay. You're You're doing fine. All right.
This is not how I make my living. You're trying to get to that point.
When you reviewed all of the medical records in that box, did you have any other descriptions of the motor vehicle crash that varied from the one that you got from her?
The only one that I recall, the only two that I recall, the description that she gave me, and the description from the traffic forensic report.
Okay. What are some of the risk factors for people who are involved in motor vehicle crashes as far as cervical and lumbar injuries?
Ankylosing spondylitis,
Okay.
number one. For osteoporosis,
Okay.
would be another one.
Women tend to have osteoporosis, one of them.
Postmenopausal women,
Okay.
more likely than men to have increased bone mineral.
What other things are risk factors? Things that might apply to Dannette Griffith.
Don't really have any other than those.
Do you think that women are a greater risk factor than men? Really? You don't think that their necks are a little smaller and thinner and more delicate than a men's neck?
I don't think that has any bearing on their risk for trauma to their neck.
Okay. There was a suggestion that, let me ask this, in any of the medical school training or any of the fellowship training or any of the board certification, was there any type of test where they actually look at photographs of motor vehicles and to determine the amount of injury that was happening to the occupants?
Actually, there was.
Really? Tell me what school that was. I'd like to
Well, it's
know.
actually during residency. It's the trauma certification. So I was actually an ATLS instructor, the American Trauma, Life Support Trauma. So you have to actually have an ATLS certification in order to perform as a trauma specialist. So it's part of your part and parcel of orthopedic training. So ATLS provides you with some guidelines determining how likely that somebody sustained a substantial traumatic injury from a motor vehicle crash. So we look at two things. We look at number one, speeds of over 35 miles per hour. So any speed over 35 miles per hour. We also look at intrusion into the vehicular cavity. In other words, if something has gone into the passenger cavity, either another car or another object, and also deployment of airbags. So those three things are the things we look at to determine if someone has a high risk for sustaining a significant traumatic injury from a motor vehicle accident.
So if you're a first responder and you come upon a scene where there's no intrusion, there's no airbag deployment, and I remember the third one, would you say, oh, you're fine, we don't need to take you to the hospital to check you out?
No, this does not initiate a trauma alert.
I see. All right. Now, I take it, Doctor, that in the vast number of patients that you treated, that many of your patients have been involved in relatively low-speed motor vehicle crashes. And
No,
that's-
not really.
No? Okay. You treat mostly people with broken bones and that sort of thing?
True, but mainly people who have degenerative conditions, deformities, tumors, infections, or major traumatic injuries.
Okay. So you don't handle many people who have cervical strain and strain?
Generally not.
Okay. You defer that to pain management, chiropractic?
They usually never get to it.
They never get to you? Okay. I know that you said you were paid $9,500 for today. This case has been set for trial at the time. Were you paid any other times?
I believe so. For record review and for depositions, talking over instrumental aspects of the case, I guess.
How much did you charge for reviewing the records?
That's usually $400.
That last was $400? Okay.
Took about 3 hours, 4 hours.
Okay. What do you charge per hour for your time?
I don't generally.
There's all these set fees.
Yeah.
When you saw Dannette Griffith, do you think at that time she was able to be gainfully employed?
Objectively,
Yeah.
difficult to ascertain, but I found no reason other than her neurologic status, essentially because she was having some cognitive issues, I felt. But beyond that, I say no, that she could probably be employed in something.
Mrs. Doctor, I think earlier when Mr. Fisher was asking you questions, you indicated that she could use some palliative care, that she's not ready to be completely discharged from treatment. I know you're saying it's not related to the motor vehicle crash. I'm not arguing that. But I think that we can agree that she does need some palliative care.
Oh, yeah, absolutely.
Okay. Tell the jury what's the importance of palliative care. What is it designed to do?
Palliative care is actually an offshoot of cancer treatment. And so someone who has a terminal illness, which you don't expect you're ever going to cure, we want to reduce their symptoms by reducing their level of pain, reducing their level of nausea. So you give them medicines and you give them modalities to try to reduce it. So they're not guided towards fixing a problem, they're guided more towards making them more comfortable during that particular problem.
Now, as an orthopedic surgeon, you order things like physical therapy, right?
Correct.
And massage.
Well, physical therapy, the physical therapist usually decides if massage is an appropriate modality or not.
And is that to help keep the patient flexible and active?
It's has a number of different goals. One is to increase range of motion in a joint, and to increase the overall body mechanics. It's to increase the strength of a particular muscle group and increase the fatiguability, in other words, how long you can use that muscle group, to improve posture, to improve gait, to improve hand use, occupational therapy. So a lot of different goals. So there's not just one specific goal.
And ultimately, it's also to improve function for the patient, right?
And not all to improve function, but that's one aspect, yes.
All right. And if the patient doesn't get that type of care, do you find that their function tends to decline over time?
They may or may not. It really depends on whether it's their initial treatment or not. There are plenty of patients who undergo physical therapy and do not significantly improve. There are patients who don't have physical therapy and do significantly improve. So it's not a causality. It's actually an adjunct of management as opposed to guided treatment.
Well, in general terms, when you prescribe physical therapy for your patient, what's the outcome that you're hoping for?
That they improve and don't require surgical intervention.
Okay. And if they don't go to physical therapy, for some reason they can't afford it or they can't get there, do you expect that their condition will probably get worse and lead closer to surgery, like you said?
Not necessarily.
Okay. Some cases maybe, some cases maybe not.
Correct.
Okay. Thank you, doctor. That's all the questions I have.
All right.
Doctor, it's been brought up about how much we've paid you and how we've had to pay you twice. And you understand why you've had to come here twice?
My understanding is that somebody...
Relevant, Your Honor.
How long will it take? Well, not your, but your personal knowledge is you can't.
My personal knowledge is that for some reason the court date had to be changed for another reason.
All right. Thank you.
Okay, any other questions for this witness?
No, Your Honor.
All right, Ms. Doctor, you are free to go.
Thank you.